Thank you very much. Thank you for having me, and I look forward to sharing information with your audience.
Great.
So what I'll do is I'll start off with a brief presentation with the audience. And as I share my screen, my topic today is going to be the use of integrative care. And I want to make sure, can you see my screen
We see
okay?
the screen right. Yep.
So I want to make use of this new approach or discuss rather, this new approach we've taken in our clinical practice to address chronic illnesses. I'm going to talk about congestive heart failure today. However, you can really insert almost any chronic illness in place of congestive heart failure and use these same principles. So, what is this integrative approach? Well, I want to talk about congestive heart failure, the pathophysiology of it, and again remind the audience of the underlying problems that contribute to congestive heart failure. And these same similar underlying problems also contribute to other chronic illnesses. So, if we look at cardiac function and abnormal cardiac function, essentially heart disease and heart failure, therefore, is just a disorder that affects normal function of the heart. So thinking of heart, normal function of the heart, it's a pump. It beats about 100,000 times a day. It's essentially a muscle with lots of complex features associated with it. It has its own circulatory system. We call it the coronary arteries. But this is how the heart feeds itself oxygenated blood. It also has its own electrical system. I spent many years working with the electrical system of the heart. And of course, it can malfunction a number of different ways. We are familiar with coronary disease. Many individuals know about heart attacks and ischemic heart disease. This happens when you have an obstruction or narrowing of disease in the coronary arteries. Here you have an acute obstruction that can happen with an acute inflammatory insult to coronary arteries of the heart. You can have valvular disease, which can develop over years. I like to think of this as an inflammatory process. Oftentimes I describe it as arthritis of the heart valves to many of my patients. And of course, there's electrical disease that can occur. There's primary electrical disease, and of course, secondary electrical disease. Atrial fibrillation is a common electrical abnormality that individuals deal with as one of many electrical problems. You can also have primary heart muscle disease. This comes in the context of hypertension, diabetes, and there are other systemic illnesses, hypertrophic cardiomyopathy, infiltrative diseases, such as amyloid cardiomyopathy. There's a lot of talk about amyloid cardiomyopathy these days in the cardiology sectors. And of course, systemic illnesses, infections, autoimmune disease, substance abuse. These can have an effect on the heart muscle. I like to think directly because it creates an abnormal milieu, which creates increased systemic inflammation, which can directly affect the myocardium itself. So heart failure basics, we think of it in two forms. We think of diastolic heart failure and systolic heart failure. Actually, most people have diastolic heart failure, even though when we talk about heart failure, you mostly talk about systolic heart failure. But individuals with systolic heart failure frequently have both systolic and diastolic heart failure. Diastolic heart failure is the inability of the heart muscle to relax to allow proper filling. So it's a stiffness of the heart muscle. Systolic heart failure in its purest form is a weakness of the heart muscles, inability of the heart muscle to squeeze or contract to eject an adequate amount of blood flow out with each contraction. So it's not a rare problem. It's perhaps really one of the leading causes. If you pick one illness, heart failure is one of the leading causes of the healthcare costs that we have in the United States. Heart disease in general is the number one killer, and heart failure is at the core of the center, I should say, of heart disease. 6.2 million adults in 2018, over almost 380,000 deaths. Nearly $31 billion in 2012. So what do we typically do? What's our standard of care in the allopathic world for congestive heart failure? Well, first and foremost is pharmacological therapy. Now, granted, we do talk about lifestyle in allopathic medicine, but by and large, lifestyle recommendations is simply, heart healthy diet and low sodium, and we don't go too much beyond that. So really, the first line of therapy in allopathic medicine is primarily pharmacotherapy. And here you have where we have different types of drugs that try to intercept the different pathophysiological processes that we're familiar with in heart failure. You have the renin-angiotensin cascade system, which is triggered. The autonomic nervous system plays a big role. There's sodium retention at the level of the kidneys. And so our therapies are directed toward intercepting some of these pathophysiological cascades to give some relief from an individual with congestive heart failure. And they could be pretty effective for a certain period of time, certainly early on. Someone who's very symptomatic with congestive heart failure, who's volume overload, gets diuretics or an ACE inhibitor, can get pretty significant symptom relief. Other therapies include revascularization. So someone who has congestive heart failure, who has coronary disease, they can benefit from revascularization either through balloon angioplasty and stenting. Of course, there's bypass surgery as well, or a combination thereof. And of course, individuals with heart failure have, or at risk, I should say, for cardiac arrest. So we have devices such as defibrillators, which can also serve as pacemakers. They can serve as an internal monitoring device. And so if someone with heart failure goes into life-threatening arrhythmia, their life can be saved by a shock. Individuals with heart failure with whom we think the ejection fraction may improve and their risk for sudden death may go away after a while, they can have a temporary or external defibrillator like this life vest. And of course, ablation therapy, individuals with atrial fibrillation, for example, who have heart failure can benefit from ablating the atrial fibrillation. It may reduce atrial fibrillation episodes or control AFib rate and have some benefit for individuals with congestive heart failure. And of course, in the extreme cases, you have individuals who are transplant candidates. They may receive a device called a left ventricular assist device, or an LVAD. You see depicted here. And again, this is a mechanical device that helps unload the left ventricle that's very weak, and it can provide adequate circulatory support for someone who's on the transplant list. And of course, here you have transplant surgery for individuals who are matched for a donor. However, these approaches can be effective in certain situations. However, there are many individuals who are too sick for even transplant. The individuals who, despite guideline-directed medical therapy or previous bypass surgery and stent placements, on multiple medications, who are very symptomatic. In fact, there's a large percentage of patients who, despite all of these therapies, are very symptomatic, who are in and out of the hospital until they meet their demise. So we really need a different approach that's not only effective, but also effective in a way where these individuals who are too sick to have multiple comorbidities, it can be effective not only for heart failure, but effective in the comorbidities. And that's where the nutritional approach is that we found is very, very beneficial. So as many of you may know, if you've seen my lectures before, it's a pretty straightforward approach. It's a anti-inflammatory nutritional approach. It's plant-based. We essentially eliminate all foods that cause inflammation. And these are foods that cause inflammation. These are foods that eliminate inflammation. So you make a change. Here's a simple step-by-step approach that we take. We use a minimally processed plant-based diet. You consume mostly raw fruits and vegetables, and certainly in certain cases, all raw fruits and vegetables. You include a variety of plant foods of different colors, eliminate processed foods, animal products, etc. Processed foods is key because you can have plant-based foods that are processed. And so it's not just about only eating plant-based, but removing processed foods of all types. And then there's certain supplements that we may use in a targeted fashion in patients, depending on their individual situation. So what's the science behind this nutritional approach, where we've looked at this in a clinical case series of some patients with congestive heart failure, which we've applied this nutritional approach. And the data show, and this is the case here, is a 3 patient with heart failure who started with an average ejection fraction of 22%. It went up to 44% LV mass. There was a significant regression in LV mass. So there's some reduction in hypertrophy. There was a trend toward increased cardiac output and a trend toward increasing stroke volume, which is the amount of blood that the heart contracts with each beat. The other issue we're dealing with is this is one individual that had coronary disease, and many of these patients with heart failure, even though they don't have epicardial coronary disease, they may have small vessel coronary disease. And this shows the effect of a plant-based diet on coronary disease. Here's someone with about 90 to 95% osteal lesion in the LAD. They frequently refer to this as a widowmaker. This is a female patient, so you may think of this as a potential widower maker. And you have a situation here where after 5.5 months, this lesion went to 0. There's no stent, no surgery, of course, and you see the left main vessel improved as well. And this person's ejection fraction went from 24% to 50%. So we also have seen reduction in Lp(a), reduction in inflammation, reduction in atherogenic lipoprotein molecules in just 4 weeks. The 4 weeks part is important because we know that this nutritional intervention has an immediate impact in individuals who are very sick. You don't want to have an intervention you start and you're expecting something good to happen in 12 months. You need to have immediate onset when these patients are in decompensated heart failure, and you need something that's going to work right away. This shows other things such as Lp(a) reduced by 16%. We're the first to show this in the medical literature. Atherogenic particles reduced by 11%. This is all in just 4 weeks. Also, you see C-reactive protein, and we've been seeing this reduction for more than 2 decades. We finally published it. 30% reduction in 4 weeks. Statin drugs, by the way, which can reduce C-reactive protein, takes about 2 years to do that. IL-6 reduced by 23%, and white blood count, even though it's starting in a normal range, had a 22% reduction, which shows that this is probably an inflammatory level of white blood count elevation. Now, in addition to nutrition, there are regenerative therapies. Now, there are a number of regenerative therapies that we use as an adjunct, and they have a synergistic effect, especially in some of our sickest patients. This is important. So I'm going to highlight a few regenerative therapies that we use at our center, and there are a couple that I'll say a few extra words about. Infrared sauna therapy has lots of data showing effectiveness in patients with congestive heart failure. After 2 weeks of therapy, there's intravenous ozone therapy, which I'll talk about a little bit, can reduce inflammation and has benefits in heart failure patients. We use high-dose vitamin C in patients that may have inflammation and coronary disease. Methylene blue is an antioxidant we use in some of our chronically ill patients. External cardiac assist, there's this device here depicted here. And this is for individuals with heart failure and angina. And we've found, and we've done this for, gosh, maybe 2.5 decades. But we've had great success with our heart failure patients and patients with coronary disease. Chelation therapy works very well with patients with heart disease and coronary disease as well. So infrared sauna therapy, we have 2 saunas in our center. Infrared sauna therapy improves nitric oxide production. It also improves endothelial cell function. It's been shown to improve circulation, lowers blood pressure, improves peripheral blood flow, reduces inflammation, and also reduces ventricular arrhythmias. And this has been seen in heart failure patients. Ozone therapy, ozone is a gas, O3, and it has the ability to increase oxygenation in ischemic sites. It does many things. Here's a complex slide that shows many benefits of ozone therapy. Key to heart failure is immunomodulation. Oftentimes, heart failure patients have an immune system that's in disarray, and essentially you control that, put that under inflammation under control, and you have improved cardiac function. There's an oxidative, antioxidative balance. So you have increased oxidative stress that's brought into balance with ozone therapy. So we use a form of ozone therapy called extracorporeal blood oxygenation and ozonation. So essentially, the basic principle of ozone therapy, intravenous ozone therapy, is that you remove blood from the patient. You'll infuse ozone into that sterile blood bath, mix it together, and so the blood becomes ozonated and oxygenated. Then it's reinfused back into the patient. EBU does that in, say, a large volume way, sort of a continuous way, and I'll show you some diagrams on how it's done. And so it's a process of infusion of patient's blood with ozone, also known as ozone dialysis. We can treat about 2 to 3.5 liters of blood in a period of about 60 minutes using ozonation. We do that right in our office. It boosts oxygen levels, stimulates circulation, enhances cellular metabolism, and support the body's natural healing mechanisms. And here's a schematic in terms of how it works. The patient has 2 IVs. We'll remove blood here, goes through a pump in this filter, which then it's ozonated. So the blood comes in, and this is where the ozone meets the blood. So the blood gets ozonated here. Then it goes back in through a drip chamber. And it also undergoes UVI therapy, which is a series of UV ultraviolet light therapy, which also has some benefits that's synergistic to ozone. And then it goes back into the patient. So it's a reinfusion of the patient's blood that's ozonated and oxygenated. Here's a diagram of the chamber. The exact chamber that we use in our center is a patient who's getting ozone therapy. They're usually comfortable in a chair, 2 IVs. Blood comes out, gets ozonated, and goes back in. You have the ultra UVI chamber that's there. Ultraviolet blood irradiation kills bacteria and viruses. It has a supercharging effect on the immune system. It also helps improve circulation. It also oxygenates tissue, provides a balancing effect, a homeostasis, reduces pain in tissues, increased tolerance of the blood towards radiation and chemotherapy for individuals who are getting chemotherapy. Has cardiovascular protection effects, has anti-inflammatory effects, and also has anti-infection properties. It stimulates production of red cells and helps improve flow and properties of blood as well. And one final word about ozonation, the best way to think of it from a cardiovascular standpoint, it enhances mitochondrial function. It has a hormesis effect. It creates an oxidative stress, which causes a rebound antioxidant effect. And so the mitochondria becomes more efficient, and oxidative phosphorylation becomes more efficient. Therefore, ATP production becomes more efficient. I want to talk a little bit about the precise way that we apply plant-based nutrition in our sicker heart failure patient. We use either cold pressed juice or green smoothie intervention. So what's the green smoothie intervention? We'll use a plant-derived water base, either coconut water or cold pressed juice, say like a cold pressed celery juice or something of the like. We may use spinach and kale. There's a super green algae that we use from a superfood. It has lots of protein in it and omega-3s. We also use a barley grass and a freeze-dried formulation, and also frozen fruit of your choice to help make it more palatable. And then we may, and we'll mix that together. So what's the protocol? So a patient comes in, then decompensated heart failure. We may have them on green smoothies only for 7 to 15 days. We may advance them to salads within that time period. And it fluctuates depending on how the patient is doing. They'll continue raw foods for another 30 days, and we may add some steamed veggies in the form of soups or boiled veggies. And if they regress, though, we go back to raw plant foods and give them more raw detox over time. So why green smoothies? Why cold pressed juice or green smoothies? Well, heart failure patients have poor gastric absorption. This is due to bowel edema, decreased perfusion to the GI tract. So they're not going to absorb solid plant foods very well. Cooked plant foods, which may be more easily absorbed than raw foods, do not have as an aggressive of an anti-inflammatory effect. So it doesn't have as much of a powerful effect and immediate effect as raw foods. So juicing and extracting juice in a natural way from these foods have this benefit. You may have partially damaged microvilli in the GI tract, as many people do, disrupted microbiome. So these normal tools that are beneficial for digestion are compromised. And so you have to help the patient out. So cold pressed juice or smoothies are very effective in that regard. So there's a nutrient-rich, pre-digested green foods that are more easy to absorb, better for intracellular hydration, which is extremely important. It enhances GI microbiome, and it's less metabolic demand of digestion, and hence less cardiac output that's required to go to the GI tract, and therefore the limited cardiac output can be used for other areas. So let me share this with you using some clinical case. There's a clinical case series that we had recently published using this approach. In essence, there were 7 patients that we looked at who went through this integrative approach using nutrition, sauna, ozone, and had different patients, different therapies. And this has recently been submitted. It's nearly ready to be published, but basically we saw that all these patients, all patients were class C and D heart failure, most are class D. So these patients were very symptomatic, who many of them were candidates for transplant, but too sick for transplant. For example, one patient was an 82-year-old lady who was sent home to die, literally to die by her cardiologist. She was on a millinone infusion pump, and her daughter brought her to the center, and she went through the program, and she's now off oxygen, out of the wheelchair. She's walking on the beach and going on trips with her daughter and the like. So she has a much better quality of life. So this is the type of transformation we were seeing in patients who are with advanced heart failure. And this case series is showing it, and we plan to do a control study in the future. Let's look at an individual patient. Sometimes it's easier to see when you say, okay, how do you apply this to a patient who's very sick? So there's a 66-year-old lady who presented to our office. She had severe mitral valve regurgitation. She had an electrical abnormality, we call it an interventricular conduction delay. And in the office, she had worsening shortness of breath, and she reported being on a plant-based diet. However, she was probably lots of processed foods, etc. But nevertheless, she had a history of lupus, and she was having a lupus flare, in my opinion. So we admitted her to the hospital. And she had severe mitral regurgitation. This next video is going to show you how bad her regurgitation is. You see severe leaking. The heart is dilated, not contracting very well. You have tricuspid regurgitation. EF is very low. Here's the aortic valve. Here's another picture. There's the mitral valve there. The heart, you see, is not contracting very well. You see that she's in severe congestive heart failure. So I admitted to the telemetry unit. However, she decompensated very rapidly. So we had to transfer to the CCU within 24 hours of being in the hospital. She was having lots of dysrhythmias, which again worsened heart failure. And this, I think, was due to lupus flare. She had systemic inflammation. So we put in a CCU and got these things under control. And so then I consulted some of my colleagues to help in terms of getting the heart structurally improved. So the first attempt was to talk to my structural heart colleague, and she had severe mitral valve regurgitation. So the plan was to do a mitral valve clipping procedure that can help control heart failure. However, the team saw her and felt that she was too sick, and said, well, we probably should just let her get her life in order and send her to hospice. I did talk to my EP colleague. I thought biventricular pacing could also benefit her, but that colleague thought that she was too sick as well. So nevertheless, we called the palliative medicine team. They recommended that we optimize her medication, get her ready to discharge for hospice. This was a list of medications she was on, included sotalol to control the arrhythmia. She was also on a millinone infusion, which is often used for patients with end-stage heart failure to give the heart some contractility, to give them some comfort, and of course diuretics. And so we did get a hospice facility that agreed to take the patient. However, there was some misunderstanding. They didn't realize the patient on Milrinone, and maybe we didn't communicate that to them well. So they sent the patient back after discontinuing the Milrinone, saying they can't manage the patient. So she was readmitted back to the hospital within 24 hours and decompensated heart failure. So she couldn't be sent to a hospice facility on the IV Milrinone. The palliative team came and said, look, we'll just, let the patient die here in the hospital after discontinuing the Milrinone. So the patient was very distraught. And so I just talked to the patient. The hospital said, let's just try one more thing. And this is when we put the nutritional intervention into action here. We put on a detox smoothie protocol. The patient started to drink only green smoothies. Now, it's important to realize it's only green smoothies. I didn't add green smoothies to her heart failure diet. I stopped everything she was consuming nutrition-wise and put her only on green smoothies as a detox for the first 4 to 5 days. Within 2 to 3 days, she was feeling well enough to eat raw salads. Her appetite improved. She was on her feet by that time and was weaned off the Milrinone within 5 days. And she had improved energy with increased ambulation and was able to be discharged within a week on just PRN Bumex. She was discharged to hospice initially, but being at hospital for only about a week, then she was able to go home. We saw her as an outpatient. This is the medication list she started on before we started the green smoothie detox, and she was only on PRN diuretics. There's a graph depicting the same. So here's a patient who got better in a very short period of time. And we were able to start this detox with the green smoothie, and we were able to wean medications. The patient got better, and it didn't take 7 weeks. It didn't take 7 months. It took 7 days. Actually, it was faster than 7 days for that matter. So what were the key reasons for decompensation first and foremost? Well, she had a suboptimal plant-based nutritional regimen. She had severe mitral regurgitation, atrial attack. She was having a lupus flare. And all these things were overwhelming our cardiovascular system and put in decompensation. And so the key reason for the recovery was a nutritional detox. Notice it wasn't just a plant-based diet, it was a nutritional detox. There's a difference. And of course, medication weaning was also extremely important because the medication can contribute to some decompensation factors of patients with cardiovascular disease. Briefly, I'll discuss another patient with you whom we treat as an outpatient to give you an idea in terms of how this works with some of the other integrative therapies. This is a 75-year-old female who had been hospitalized with hypotension and weakness and fatigue. She had the sensation of feeling that her feet were numb. They, as she described it, that the feet doesn't come with her when she walked. And of course, she was diagnosed with atrial fibrillation and underwent a cardioversion. She came to our center to improve her overall health. So she had been plagued by these chronic illnesses that she had flown into Houston, into our center. And basically, we initiated a nutritional detox in her case because, again, that's always the first step to nourish and cleanse and hydrate the body. So the detox started off with her with we started her on, I think, either juice feast or smoothie feast. In addition to that, she received intravenous ozone therapy in the form of EBU. She also received intravenous vitamin C. We gave the vitamin C because of a history of atrial fibrillation. She also has a history of renal failure. Her GFR was 17 with an EF, if I remember correctly, of about 30 to 40%. And she, of course, received blue-green algae because she also had systemic inflammation, arthritis, received liposomal curcumin. So this is an idea how we use targeted supplementation, targeted regenerative therapies, along with the nutritional detox in our center. So she had been staying on a plant-based diet and feeling much better. After 4 weeks, she was able to walk without shortness of breath. And essentially had more freedom. We reduced some of her medications. The C-reactive protein went from 10 to 0.3. Her GFR went from 17 to 30. At 17, she was near the brink of needing dialysis. A GFR below 15 gets you declared as an end-stage renal failure and gets you on dialysis. So she pulled away from that number. She actually has come back to our center to get more improvement. Her ejection fraction went from 42% to 54%. And so that showed significant improvement there. So another case where the reduction in inflammation was great, improved cardiac function, improved by nearly 30%, renal function improved by 76.5%. But what's important in this patient, which is hard to measure, is that she had improved functional status, she had improved mobility, she had increased freedom and increased confidence. Oftentimes in medicine, we make the numbers look better, but we don't make the patient better. What I like about this integrative approach, yeah, the numbers get better, and this is great to show because we have to show the science behind it. But what's also important is that in the context of this type of therapy, the patient has more freedom. The patient, if she was on a transplant list and getting an LVAD, yeah, her EF could get better, her renal function can get better, but the patient may be lying in a hospital for months at a time because of the need to manage all of this technology. In this approach, the patient, these numbers get just as improved just as much, but the patient also is not suffering from the comorbidity of the treatment. So heart failure can be defeated, and we have the power to do so. So I'm going to stop my screen share, and I will open the floor to questions, comments, smart remarks, or whatever you want to send my way.
Okay, great. Thank you so much for that awesome presentation. So real quickly, how can people get in contact with you, follow your work? Would be the best way.
So our website, montgomeryheart.com, is a way to get to our website that sees you get information about our center. We have online programs, online community. We work with patients with online coaching, and there's a lot of things we have. We have a very active YouTube channel. Go to YouTube. It's at Montgomery Heart Wellness on YouTube. And we actually show a lot of, we have clinical case rounds, and every Wednesday at 7:45 Central Time, I present a topic, maybe it's on atrial fibrillation or the like. The clinical rounds are used to discuss patients like the one I presented, and we give you an insight in terms of how things work. Also, you get some information from the patient. It's pretty educational, and our audiences really like those things. So those are the main ways that you get in touch with us. And individuals who need to fly down, they can call us, and we can get your clinical information and go from there.
Okay, and for people interested in getting Dr. Montgomery's books, they are available on our bookstore at therealtruthabout.health.com, and you just click on the bookstore in the top of the menu, and you'll find Dr. Montgomery's books. So now
I'm sorry. One other thing, and I don't know if you have videos or docuseries. We have a docuseries, The Heart and Soul of a Champion. If you go to heartandsoulofachampion.com, we have season 1 of a docuseries, and we actually chronicle the lives of people who've gone through our program. It's much more in depth. And so you can go to that page. If you go there, you get your name and email address, and you'll see on the page, you can see the trailer, but you can get episode 1 of season 1 at no cost by leaving your name and email address. And it shows how the season 1 athletes edition went production of season 2, which is chronic illness in women. And so we show how this works in different capacities. Here we had some retired professional athletes, some who were world-class track athletes, NFL Hall of Famers, and they've gone through our program, and we've shown how these individuals in their 50s and 60s have gotten athletic performance almost back to when they were competing. So it shows the power of this intervention, not only in individuals who have advanced heart disease who are in the hospital. These may be individuals who once were, champion athletes who have chronic illness, who reverse the illness, but also get back to their championship form. And it's Heart and Soul of Champions, not only about athletes, but everyone can get back to their championship form, where you were once a professor or a school teacher or or concert pianists or whomever. We've all had a championship form once in our life, and perhaps you may want to get back to that. This is an approach that can help you do that.
Great, thank you. So we're going to begin the Q&A portion of our presentation. And for any audience member that's interested in asking a question, you can go ahead and raise your hand. And we already have a couple people, and we've just put the instructions on how to do so in the chat. So first question. So I want to get clarification. So we were in a panel the other night, and you were in there with Dr. Brian.
Mhm.
And one of the items that came up was cholesterol levels, and obviously that's a huge concern of people. We've been taught that, especially in this community, that the lower the better. There's an idea that below 150 is heart attack proof. I have T. Colin Campbell coming up next, so I'm going to ask him the same thing about cholesterol. And Dr. Brian was saying something that was counter to that narrative, and you seem to agree. So I don't want to put any words in your mouth, but I want to get clarification on that. So Dr. Brian was basically saying that the healthiest people, the people who had the best health outcomes, and correct me if I'm wrong, were people who had higher cholesterol. And he was saying something around 240 to 260, if I remember correctly. And and then I believe it was you, or it may have been him, that stated that if you are living a healthy lifestyle and your cholesterol was still high, it could be because your body needs to produce more cholesterol. So can you tell us what the ideal range is, and just clarify that, because it's obviously quite I'll say controversial, especially in this community.
Sure. Let me So that's a great question. So let me clarify what what I'll do is this. I'll clarify what my understanding of what Dr. Bryan said is that he actually quoted an observation in the Framingham study. In my recollection, he said that individuals in the Framingham study who had longer lifespan just happened to have higher cholesterol. And I think that was the understanding he had. There wasn't a cause and effect. He was stating an observation. Now, and of course that raised eyebrows. When you look at cholesterol, in particular LDL cholesterol and total cholesterol, there are studies that show by reducing LDL cholesterol, you see an association with decreased cardiac events. You have to look at, the totality of things. So, for example, if somebody has gangrene on the foot, so you take a group of people with gangrenous left feet and they get amputation, or maybe just have people with bilateral gangrenous feet, and they get bilateral below the knee amputation. There's a benefit to amputating the legs in those individuals because they have bilateral gangrenous feet. So if the gangrene gets worse, the patient gets sicker, and so in that population, bilateral amputation is better. But then, if you then do a population observation, and you say people who have amputations have a lower lifespan. I'm not saying this is true, but I'm just making it. People have more amputation, have lower lifespan, because they're less mobile, they're predisposed to DVTs than people who are ambulatory. So you say, okay, well, this therapy of amputation is effective in this disease state, in this setting. But if you look at a total observation, people with bilateral amputations have a problem. And so both can be true, and you have to understand the context in which those things exist. Let me give you another example just to try to drive the message home. People who are diabetics, who are hyperglycemic, because they're hyperglycemic with diabetes, are worse off than someone who's not hyperglycemic with diabetes. Okay, great. So then if we come up with a therapy and we lower the blood sugar, aggressively lower the blood sugar, they should do better with people who don't have lower blood sugars aggressively lower. But if you think, well, okay, that should be the case, but no, it's not the case. There's studies showing that aggressive blood sugar control is not as effective, is worse than less aggressive blood sugar control. So it seems to contradict, but it's not really a contradiction because low blood sugar is not a state function. Low cholesterol is not a state function. And what I mean by that, when I say something's a state function, if something's a state function, it doesn't matter how you get there. In the case of medicine and these biological markers, it does matter how you get there. And so if you see a situation where individuals who have a lower number for a certain reason, it doesn't mean that the fact that that number is lower in and of itself is going to give them a better overall outcome. It depends on how that number is achieved. It depends on the circumstances, et cetera, et cetera. And so that's really the gist of the comment. And you have to think in terms of associations and not necessarily cause and effect in all of these situations.
Thank you. And so things like statins to lower cholesterol, what are your thoughts on that? Are we actually getting to the root problem of heart disease when we take a statin, or are we just masking a benchmark?
I think we're more masking a benchmark than we are getting to the root cause. Now, if somebody's eating cheeseburgers or whatever case and their cholesterol's high, you get a group of people doing that, and you give one group a statin and the other group you don't give a statin, you can probably show a benefit. You can probably show some difference. Statins can reduce inflammation, they reduce cholesterol, and you can probably show, and it has been shown, you can reduce progression of atherogenic plaque. So I'm not saying it has absolutely no benefit or potential benefit, but if you look at the totality of it, somebody taking a statin for 20 years, for example, there are also adverse effects to taking a medication over a long period of time. You have to look at, when we look at these studies, the statin drugs, they range from about 2 to 6 years, okay, in certain populations. Okay, so what's the benefit of a statin drug if you do it for 15 years? We haven't done that study. And granted, say, oh, well, they're registry data, blah, blah, blah. But no, we haven't done that prospective study looking at statins for 20 years. And would that study be different? That's the other thing. Drug-drug interaction. We did the statin drugs. Did we have GLP-1 agonists on board? There are new drugs and other drugs that are coming out, new indications that are being applied to the same patients. So we don't know what the drug-drug interaction of a statin with some of the newer drugs out on the market, and could that have an effect on their efficacy? And so there are a lot of factors that are not looked at, and by and large can't be looked at in these studies. And so we have to step back and use a certain level of common sense to say, well, one, these pharmacological agents are by nature foreign to the body. Okay. So nobody's that I'm aware of is born with a genetic statin deficiency. So we're not correcting a biological abnormality. We're correcting a biological marker, which is outside of the range of biological norm, but we may be doing that in a certain way that's either beneficial for a certain period of time, but not necessarily beneficial for a long period of time. So that's what I want people to understand. It's not, we say, oh, heart attack proof. Cholesterol less than 150. I've seen people heart attacks, cholesterol less than 150. It's how you get there. And the other thing is that it takes more. I mean, high cholesterol is not the only thing that causes a heart attack. There's a constellation of things that can come together and cause a heart attack.
Yeah, and I think within this community, when people say heart attack proof with cholesterol below 150, they're talking about by lifestyle changes, not through medication. Right?
Understood. But again, you want to be careful even in that context, because you don't want to measure it on one biological marker. When we look at patients, we look at information, we look at lots of things.
Sure.
And so you can have an acute inflammatory insult with a low cholesterol on a quote unquote plant. The patient I presented was on a what? Lifestyle plant-based diet. And she's had increased inflammation. I don't remember what her cholesterol was. I don't think it was very high. Now, she didn't have a heart attack. She had acute decompensated heart failure. But again, you have to look at these things in the constellation. The human body is so biologically complex. what I want to convey to the audience is that we shouldn't just break it down to one biological marker. Number one, if we take all the biological markers we know about, there's probably less than a fraction of a percentage of all the ones that we need to know about to understand the body fully. And so we can't, I don't want to just sort of jump to that. Yes, having a lower cholesterol with lifestyle is great. We look at that, we encourage that, but we don't make guarantees based on that. And we don't, use that as the only component.
So speaking of biological markers, in your opinion or your experience, what are the essential medical tests that everyone should consider getting either regularly or periodically to ensure optimal health and early detection of potential health issues?
Typically, what we use is the echocardiogram. It gives you the size and function of the heart. We use a stress test. It gives us information in terms of your hemodynamic response to exercise, heart rate, and rhythm. From the standpoint of blood test, of course, a resting EKG. Blood tests we use, of course, we look at lipid panels. We look at inflammatory markers, C-reactive protein, myeloperoxidase. We look at PLA2, which looks at plaque formation inside the coronary arteries. You look at particle sizes, particularly with look at the small particles, ApoB. We look at, of course, renal function. We look at blood count, make sure the white blood count is not very high. So these are many of the basic things that we look at, both physiologically and biochemically in our patients.
Thank you. And beyond the medical tests, and obviously including those, what information such as diet, what people are taking as far as supplementation and other things would you also consider in your evaluation of someone's health, and what should the general public be looking at for themselves?
So when we look at diet, we sort of back off and we kind of go to foundational things. So our recommendation for our patients is optimal hydration, fresh air, sunshine, of course, proper sleep, and the like. Now, you may say, well, those aren't all dietary things, but it's really how we are nourishing the body. So fresh air, sunshine, hydration. Now, hydration, for example, many people say, okay, I get a plastic bottle of water, I drink about 8 bottles of water a day, I'm hydrating. We like for our patients to, eat their water as much or more than drink their water, meaning that you want to consume hydrating foods, cucumbers or melons or that type of thing. So you want to hydrate through natural plant foods because that's more structured water. It's probably going to be perhaps the healthier form of hydration. And what we found in our clinical observation, we haven't formally studied this, is that patients are better hydrated when they're consuming plant-derived water. Fresh air, sunshine, of course, movement I didn't mention earlier is also very important because, again, vitamin D is important. You can't get it all in a supplement. You need the radiation from the sun. We sometimes recommend UV lamps for individuals who are not able to get out very much on a regular basis. But yeah, so from a nutrition standpoint, fresh air, sunshine, hydration, proper movement, proper sleep, those things are, they support proper nutrition and the like. And of course, filling your mind with proper things as well. Okay, nourishing the mind. What you read, what you look at, what you focus on a daily basis also has an impact on your overall health. So that's the approach we take from a global standpoint with our patients.
So you just mentioned structured water when in the context of eating your water. What do you mean by structured water?
There's some people have done some scientific work and looking at alkalinized water. Some people have put crystals in water, and they've studied how structured water is better than unstructured water. I don't pay much attention to that. What we've done is, and I said this is on a clinical observation, when we've had individuals, for example, I've had individuals who are on dialysis, who are on restricted fluid restriction. And so they're on the fluid restriction, let's say 900 mLs a day. When they restrict that fluid to inorganic water, so they're drinking it, they're always thirsty. I've taken similar patients and put them on a juice feast where instead of 900 mLs of inorganic water, they're taking 900 mLs of cold pressed juice. In that setting of 900 mLs of cold pressed juice, they're much more hydrated. Their numbers show them to be much more hydrated, and also dry mouth and all those. The sense of thirst is gone. Patients who are not in stage renal failure, we see them get more hydrated in terms of reducing increase in GFR, reducing creatinine, and other parameters showing improved hydration. So anecdotally, we see improved hydration when you consume plant-derived water. Water that comes through a plant, I think, is biochemically different. And it may, what we approximate when we do these things like crystallization of water or alkalinizing water, it probably approximates what you get in plant-derived water, but I don't think it's quite perfect. And along the lines of plant-derived water, I think plant-derived nutrients in general are better. Now, I put an asterisk by that comment largely because, lots of things are done to our food sources. You're spraying things, the soil's less optimal, et cetera, et cetera. So there's that disadvantage. So we have to be more selective in terms of how we procure our food. So this whole aspect of nourishing the body has become more and more complex over time.
Thank you. So, so your center combines medical and wellness care. How does this holistic approach impact patient recovery compared to traditional medical practices alone?
It has a big impact on recovery, largely because in the context of a very sick patient. So in this case series I mentioned, one example I mentioned, alluded to rather, was an 82-year-old lady who was wheeled in. She had had multiple heart attacks, stents. Her heart was initially at 20%. She was put on milrinone, and the heart ejection fraction went from 20% to 50%. So even though the ejection fraction was better, she couldn't walk a few feet without being short of breath. She was on oxygen. She was just debilitated. And so by putting on the integrative approach, she immediately started getting better. So the recovery we find is faster because you have to think when someone undergoes a traditional medical therapy, there's an insult to the body. Let's say you undergo bypass surgery or a stent or whatever the case is. There's some level of intrusion and insult to the body that you have to recover from. And the weaker the body, the weaker the frame of the patient to start with, the less likely they're able to survive the treatment. That's why people have to get surgical clearance. Surgeons won't operate on the sickest patients, even if it's bypass. I've had patients come in with heart attack, with lots of comorbidities, heart failure. The surgeons won't even do bypass surgery. The patient's too sick for bypass surgery. Many patients who are theoretical candidates for heart transplant. It's supposed to be the most advanced treatment for heart failure. They're too sick for heart transplant because the body can't tolerate it. So these traditional therapies, which are supposed to be very powerful, are also very taxing on the body. What I like about this integrative approach, it immediately starts to heal. Okay, you saw this patient who's, and that's why I like to present this case, and there are others I have like it, who's very sick. Within hours to days, started getting better. And that's the power of the nutritional approach. And then we add these other integrative approaches, which then have a synergistic effect, which can help with long-term benefit. And we've seen great benefit with this approach. So not only is it more effective, it's more effective in sicker patients. These people were too sick for the treatment. So when you think about it this way, you have treatment A, B, C, and D, okay? In theory, treatment A is your lower level treatment, and treatment D is your highest level treatment. So in theory, the highest level treatment should be able to treat the sickest patient, right? But I've shown you how the highest level treatment in allopathic medicine is either bypass or heart transplant. But patients are too sick for heart transplant. So what do they have to do? They have to go to the next level. What? Integrative. That's the best. And not only integrative is the best for the sickest, guess what? They can treat patients at level A2. If somebody come with mild heart failure, they can be treated with integrative too. But it's not appropriate to transplant a heart with somebody with mild heart failure, mild heart disease. And guess what? Integrative therapy can be treated for healthy people who just want to have better athletic performance. So with this integrative therapy, you can treat the sickest of the sick and the what? Wellest of the well, and everybody in between.
So it sounds like conventional medicine, or you're saying, and correct me if I'm wrong, that conventional medicine often gets lost in treating benchmarks and it's not really focused on the end results. If that, assume that's correct, what benchmarks do you find conventional medicine gets lost in focusing on treating that benchmark without really being concerned with the overall health and the outcomes of the patient?
There's several. In heart disease, you mentioned cholesterol is one. Somebody's had any cardiovascular disease or at risk. That's the whole idea. Okay, put them on a statin to lower the cholesterol, get as low as possible. Ejection fraction from the standpoint of heart failure patient, get the EF up. If you have ischemia on stress tests, and you get a coronary angiogram, you see a 70% stenosis, you go and fix that lesion. And so it's all about the numbers, getting the cholesterol down, the EF up, and these things. And I'm not saying these things are inherently bad. It's just that we have to always put these things in context. So benchmarks of cholesterol, biomarkers, inflammatory markers, these things are important things to look at. We look at them ourselves, but we have to look at them in the context of how the patient is doing. So that's why I like the natural approach, because what you're doing, you're nourishing the patient, you're letting the body do the work, and the body's going to get the numbers where they're supposed to be. The information may not always go to 0 or less than 1 as fast as I like, because there are other things going on in the body. The cholesterol may not always come down to whatever that ideal number is for various reasons, because there are various things going on in the body. So I have to recognize that. And maybe I'm saying, well, okay, the nutritional intervention is not as optimal. Maybe we'll improve it, or we'll give it time to see if those numbers continue to come down and continue to improve. So we always have to put these things in the context of how the body's healing itself, and not just strictly look at the numbers without regard to other aspects of the human frame.
So it's very popular, to look at genetics and say, oh, everything's genetics. It's a great way of taking the responsibility off of the individual for their own health outcomes. What role do you believe genetics plays in heart disease and health in general? And how can diet and lifestyle modifications alter genetics predispositions?
Yeah, some mornings when being too lazy to get up and work out, I say I'm genetically predisposed to lay in the bed. Um, that's a great question. I get it a lot. The way I like to explain is the following. Let's say, for instance, you're an architect and you draft a blueprint for this beautiful home. And you have all the details, the drywall, the plumbing, et cetera, et cetera. And so you have the blueprint drafted, and you have this beautiful design for a home. However, you go to the empty lot where the home is supposed to be built, and there's no home there. Okay, there's no home there because the home hasn't been built. So the blueprint's there, but the home's not there. What does it take? Well, you have to hire a contractor to then look at the blueprint and then build the home. That's called the expression of the blueprint. So the contractor is the source, and the subcontractors, of course, are expressing the blueprint in the formation of a beautiful home. And so once that blueprint is looked at, and then materials are brought in and is expressed, then you have the home. So let's take, for instance, somebody who has a blueprint for diabetes, type 2 diabetes. Again, they have that blueprint, but you can be born with that blueprint. But you have to hire a contractor to express that blueprint for diabetes. So that contractor is a poor lifestyle. That contractor is a poor diet, sedentary lifestyle, excess animal protein, processed foods, etc. And so if you hire that contractor and give that contractor enough time, just like the contractor may need like 18 months to build that house, maybe your contract for your diabetes needs like, 18 years to build your type 2 diabetes. So you have 18 years, you're hiring that contractor to express your diabetes genes. So after 18 years, you go see a doctor, says, oh, you've got diabetes. Somebody else has a blueprint for congestive heart failure. They contract somebody to what? Build a congestive heart failure home. And lupus, et cetera, et cetera. Maybe you have several blueprints and you hire multiple contracts. Say, oh, I want diabetes, I want heart failure, and I want lupus too. So I want 3 homes. So it's the expression of the genetics that we have to deal with. So what we have to do with lifestyle, we have to go in and fire those contractors. And then we hire a demolition crew to tear down that pre-constructed diabetes, tear down the pre-constructed heart failure, tear down the pre-constructed lupus, et cetera.
So I just have to say, I love all of your analogies, both today and in the panel. So the term epigenetics has become extremely popular. That's what it sounds like you're talking about. Can you give a definition of epigenetics, and if you haven't already answered it, how that...
I mean, epigenetics, I like to think of the environmental influences. I mean, so that's the environmental influences that trigger mRNA activity that brings about the expression of a condition, if you will.
Okay. So now I'll let you answer this if you'd like to or not, because it's a little controversial. You brought up the term mRNA. One, I'd like to, if you can explain what that means, and then also it's being used now as a technology, and I don't know if a medicine or a procedure in general, and it seems becoming, the plan seems to be that it's becoming more widespread and used in many things. What is your thought on that technology for as a therapy? Is that, in your opinion and experience, and based on the research you've seen, the right way to go? And I'll let you answer the question, or we can move on based on...
Now, I don't mind answering the question. I mean, the mRNA basically basically you have as I said, the DNA. You have to copy that DNA, and you have RNA that's used to copy the DNA, and then certain components of RNA, and then proteins are made from the photocopy of the DNA, which is in the form of an RNA, and then proteins are made that way. So that's an oversimplification, obviously, but I just wanted to kind of say you go from DNA to RNA to protein development at the cellular level. So it's where these proteins are put together when you have the expression of, say, an enzyme or some other molecule that have amino acids and cofactors that then carry out some of the function, whether structural or enzymatic in the body. So that's how our body produces things that carry out a function of our body, whether it's hormonal or strictly enzymatic or structural, et cetera, et cetera. Now, in terms of mRNA technology, we're talking about, immunizations and the like. When you get into this situation where we are manipulating the human body, manipulating the immune system, I think it's very dangerous. The body is fearfully and wonderfully made. And our immune system is designed, we have our built-in immunization of vaccine system. It's called the immune system. And when the body is exposed to a foreign agent, it has the ability to immediately respond to it, and then it has the ability to identify what it is and then create a later response to it. The reason that system breaks down is because the same reason the system breaks down with diabetes, heart failure, and arthritis, all these other conditions. We destroy the body. We put the body in immunosenescence, which we suppress the immune system, or sometimes I should say the immune system's in disarray. And so when you're invaded by a bacteria or virus, an immune system that's in disarray is not going to function properly. And so when an immune system functions properly, you contract a bacteria virus, you immediately address it. You have mucus formation, fever, these types of reactions. Because if the response is immediate in the context of a healthy, alert immune system, these reactions such as fever, inflammation is not overblown. And so what happens is that the body's immune system attacks, kills, suppresses the invading foreign agent, identifies it, gives it to the secondary immune system, which later on can identify it further, and you have immunization. So we're really immune to foreign agents from the start, even without the introduction of a vaccine of any type. It's just in a healthy immune system. The reason we die from these foreign agents, such as viruses and bacteria, and this is a mechanism of death. This is nothing new related to the recent pandemic. The reason we die from these things isn't because we lack the ability to identify them as foreign. We die from because we have an immune system that's in disarray. And the immune system that's in disarray, that's disorderly, is going to attack us. So think of it this way, to use another analogy. So let's say, for example, you're some billionaire and you have a mansion and you have guards, you have security system. And so your security system, you have guards at the gate, guards at the front door, guards on the roof, they have weapons, etc. And so the guards, when they're alert and attentive, when somebody comes up and they don't meet, the criteria, they're not identified properly, the guard's going to immediately stop the person. And if the person tries to get through, they'll arrest them or shoot them and take a picture and say, this person tried to get in. And so we'll be on the lookout. They'll send them to the authorities. That'll be immediate. But let's say your guards, they're not alert. Let's say they've been drinking. They're not sleeping. So they're a little bit inebriated. So they're not quite conscious. So let's say not only one person comes up to the gate and sneaks by, but maybe 2 or 10 people sneak by because the guards are kind of half asleep, half awake, half asleep. So they don't know if someone's coming in. So they get to the front door guards, half asleep. So they get into the house. So the intruders are in the house, not just one at the gate, but 10 in the house, maybe 20. And then they start to make noise. Then all of a sudden the guards are startled. So the guards are startled because the intruders are in the house. They've penetrated more, and the guards start to overreact. So now they start to go in the house and start to shoot the intruders. Guess what? They start to shoot the people who live in the house. So there's this mass shooting, random. The guard, they don't know who's who. So they're shooting intruders, they're shooting inhabitants, and you have this major overblown reaction by the guards because the guards are impaired. That's what happens with the immune system. When you have an immune system which is impaired, its response to invasion is not immediate. So therefore, you have more bacteria, virus get in. Then its response is delayed and overreactive. And the mechanism by which people die from, the recent pandemic infection or any bacterial infection is due to an overreactive immune system. It's not due to the virus or the bacteria. The virus, bacteria is long dead. But then it's the immune system over. That's why you have to give them steroids and autoimmune treatments over time. That's why you have things like long COVID or strep throat is another example, well-known example of an autoimmune system that's due to immune disarray. So these things have been existing in biological systems for a very long time. This is nothing new with this late pandemic. This is basic biology 101, medical school 101, everything else 101.
So for people who have been exposed to the mRNA therapy, is there any way to clear it out once it's been introduced into the body, or is that part of your DNA now?
That's a great question. I don't have an absolute answer to that question because I haven't looked at the literature. What I can share with you is the following. My understanding, first and foremost, of this is that the design of that mRNA therapy is such that you are given the tools to produce the antigen on an ongoing basis. And so the way it's designed to where normally if you get an infection or you get an immunization, you get an immunization where you get a piece of that antigen that's either killed or weakened, etc. Your immune system sees it, reacts to it, creates antibodies, and it goes that route. This system is where you're given in a piece of the RNA of the antigen itself. So then you're given that in a capsule, and it's designed to where you then can make that antigen inside. So it's not like the injection gives the antigen, the injection gives the RNA, so you can now make the antigen on an ongoing basis. That's one. That antigen that you're making, it's in and of itself has a toxic effect on the body. And so that's where you get a lot of this long-term effects, because there's an ongoing expression of that antigen, and the antigen itself has a toxic effect. And of course, you're trying to make antibodies to it. Now, of course, that antigen is outdated because the stuff that's in the environment has changed. So what you're going to be exposed to is going to be different than the antigen you're making, because that antigen you're making is based on a previous agent who's undergone a nose change, and so the descendants of that original looks different. So there are multiple problems. One, because your immune capacity is taken up making an outdated antibody, you have less immune capacity to make an updated antibody to the new stuff that you should be making antibodies to. And that's been borne out even in flu vaccines, where individuals who get flu vaccine are predisposed to other viruses because you're making more antigens for flu vaccine, but then you can't make the to RSV. And so you're predisposed to getting RSV infection after giving this immunization. So the immunization, as opposed to letting your body's natural immune system do what it knows to do, you're tricking the immune system. You're forcing it to do something that it really shouldn't do. And we don't understand the immune system well enough to do that.
Thank you. So, in your experience, what are the most common misconceptions about heart disease and diet that you encounter?
There's no relation.
Do you find that misconception to be prevalent in the medical profession itself?
Yeah, many of my colleagues, it doesn't matter what you eat. I mean, you have people on a heart transplant the other day, oh, you get out, you can eat whatever you want. I mean, it's the most ridiculous thing I've heard. Because see, the thing is this, and when I was in medical school, people get bypassed, oh, the heart's a fix. What's happening is that when someone has an acute cardiac event, and let's say you halt that event, because I mean, stents and bypass have their place. I'm not saying they're not effective. They have their place in selected individuals. I've seen a person who would be dead if they didn't get a stent at the time you got it. So let's say you get a stent and you have massive heart attack, you're in cardiac arrest, you get a stent, it resuscitates you, you're better. Okay? That's great. But that's when you need to put them on the detox right there, right in the hospital. Raw fruits and vegetables only, smoothie, detox. That's when you need to do that. You don't give them a cheeseburger the day after they got the stent been resuscitated. And that's the disconnect that we have in medicine. Because see, the underlying problem exists. If I had someone has a cardiac arrest to get stented, get resuscitated, great. You've saved their life, but they still have an underlying disease process that hasn't been fixed. And they're predisposed to having another cardiac event sometime later in their life.
So one of our speakers yesterday, continuing on this subject, one of our speakers yesterday was saying how medical schools are getting better at educating on nutrition. However, Michael Greger had a video out in just as late as August talking about how that's not the case, and how there was a bill being passed to increase the amount of nutrition education in medical schools, and the big medical organizations lobbied against the bill. What are you finding with the state of nutrition education in medical schools?
There are 3 medical schools here in Houston. I'll have to be honest, I know very little about the curriculum. My understanding from seeing medical trainees come out, these are residents and fellows, is that, and these are ones who are within the last 3 years of medical school, is that they're totally oblivious to nutrition, as I understand. And this is in my, corner of the world. So I haven't looked at the data looking at medical schools across the United States, but from what I've seen, the trainees I've worked with or am exposed to, they have virtually no exposure to nutrition that I'm aware of from whom I've worked with.
Great, thank you. Can you discuss any recent studies that have influenced your approach to treating heart disease with diet and lifestyle changes?
Really, the ones I share with you in case, and also the case series we just showed with the integrative therapies, and this is something we're excited about. You know, science goes through this progression, if you will. You start off with observations in isolated patients, and you see 1, 2, or 3. You say, okay, let's look at this broad scope, and we're in this whole process. So we recently, in the last 18 to 24 months, have started applying these other regenerative therapies, particularly like ozone. We've done IV vitamin C in certain situations and so on, but ozone therapy, plaquettes, chelation of a patient, and a very difficult patient with back cord disease, et cetera. We've done ECP therapy for about 2.5 decades. But using these integrative therapies in conjunction, so there's a synergistic effect. So it's one thing to say, okay, I'm gonna put you on a plant-based diet, and you start exercising, et cetera, et cetera. What we've started doing in this case series I just mentioned, and it should be okay for publication within 24 hours from now, we're actually seeing a benefit to the synergies of these therapies being applied immediately. Not only that, adding exercise, which I didn't mention in my talk, but at our center, there's a sports complex, which is, blocks away from our center. And we have a corporate contract with them, where not our employees have access, but our members of our life source programs have access to it. And we have 2, soon to be 3 contract trainers who work with our clients. So you have, whether it's congestive heart failure, for example, one of our clients who had cardiac arrest, and he was on the West Coast and had a cardiac arrest, and was put on life support and dialysis and told he needed a transplant, and he refused all that. They took him off that, but I don't think he really needed it, but nevertheless, he came to our center, and he's gone through all these integrative therapies. He's working out with a trainer. I mean, they're not just doing walking. I mean, he's lifting weights, and he's sweating. I mean, so he's working out with a trainer. So these synergistic effects in people with severe disease get rapid, aggressive recovery, and they're in the gym. We've had, if you look at Heart and Soul of a Champion, one of our patient that he has a LVAD, I'm not an LVAD, but a life vest. I mean, a life vest on defibrillators that congestive heart failure, working on the gym with a defibrillator. So, we apply these therapies synergistically, and we're finding a major benefit to early application of these synergistic therapies, as opposed to you say, okay, somebody's in heart failure, decompensated heart failure in the hospital, they get diuretics, and you watch them for a while, fluid restricting, they come out, maybe you get a little bit of physical therapy, so these things are kind of stepwise. We're doing it sort of all at once. And we're finding success because of the way we do these therapies. That's the nutritional, integrative, regenerative therapies. And we find that people get on their feet fairly quickly with this approach.
So yesterday, I had the pleasure of speaking with Dr. Kim Williams, who did a presentation, and he actually referenced one of your studies, by the way, in his presentation. And as one of our participants points out, he wasn't a big fan of chelation therapy because he said it mobilizes sequestered plaque, which are aren't currently dangerous, but then will become dangerous during chelation. What's your response to that idea?
Hasn't been borne out in the studies. In fact, there were multi-center trials done. Now you have to remember, chelation therapy and ECP therapy, I'll put those two together. These are therapies that are not thought to be popular within the medical community. So for example, if say like a device company comes out with a new device and they do a study and there's some problems with it, they'll go back and rehash the study, et cetera, until they get it right and say, okay, we found this benefit, let's release it. Chelation therapy wasn't that kind of a therapy. The chelation therapy was a therapy that the cardiology community frowned upon, I should say. And so what they did was a multi-center trial to disprove the effectiveness of chelation therapy. And that multi-center trials showed people, especially those who come from heart attacks and diabetics, had even more benefit, had 27% improved outcomes. Now that's better than stenting. I mean, stenting, if you do elective stenting in patients, in the Courage trial showed that there was no benefit in patients with a stent. Okay. Now, you want to talk about potential adverse effects. Let's talk about it. If you have somebody with coronary disease, and I do a coronary angiogram, and I look at the angiogram, I see someone, okay, I see a 70% lesion here, 80% lesion there. And we talked about this in our discussion with Dr. Brian yesterday. But then on the angiogram, I don't see that 10% lesion. Or maybe I see the 20% lesion. It looks like I'm not going to stent at 10%. In fact, you're not allowed to stent at 10% or 50% lesion. Maybe 60% if the FFR numbers are right. But the point is, I'm going to stent the 90% lesion, 7% lesion. Well, good chance that those lesions are more stable. Because 7% lesion, for the most part, some you can have the rapidly developed 7% lesion, but those long lesions, oftentimes they have collaterals. But those lesions that develop over a long period of time frequently are more stable than the ones that are 10%, 20%. So I go put a stent there. Well, what happens when I put a stent in that lesion? Well, I'm increasing inflammation because I'm causing lots of trauma in the artery. Well, what happens with increased inflammation? Well, a stent that's 10%, 20% is vulnerable. If I increase inflammation, that creates the potential for that lesion to rupture later on. So elective stenting, in my opinion, is more of a problem than chelation because you're having an adverse effect. Now, what we've seen in our chelation patients, again, we're gonna have to publish it, but anecdotally, we're seeing is evidence, biomarker evidence that endothelial function is improving in those patient chelation. Now, the tricky part about chelation, because you're chelating things, you have to keep up with their electrolytes, the calcium, magnesium, and the like. And so we do that very aggressively. But chelation was shown to have a beneficial effect. So it was listed as a class 2 beneficial effect for treating angina. But this was at the dismay of the cardiology community. Same thing with ECP therapy. So again, it's one thing to have a theoretical concern, and I think that's appropriate. But the facts are what they are, and our clinical experience with chelation has been one that's very good. If we were saying if Dr. Williams' concern was being realized with chelation, I think we would have seen it by now, and that therapy would have been deemed contraindicated. But the reason that therapy is being allowed because it's been shown to be beneficial, and that's in a setting where they weren't standardizing the chelation therapies. We use a 3-hour protocol. Some people use a 1-hour protocol. The amount of chelation that's used can vary. So you saw a benefit even across the board when you weren't standardized. Just think of when you start to standardize the therapy, how much better it can be.
Great, thank you for that answer. So, in your book, The Food Prescription for Better Health, you discuss reversing diabetes. Now, most people, when they think of diabetes, they think of blood sugar, and we tend to think, I think most people tend to think of these diseases as being separate for each other. What is, and I know you've discussed this, but what is the impact of diabetes with regard to heart health? And can you explain the mechanism by which a plant-based diet impacts insulin sensitivity and blood sugar control?
Yeah, type 2 diabetes is one where it's insulin resistance. And so you have it's really, I like to refer to it as a metabolic disease, not a blood sugar disease. And because you have abnormal metabolism inside the cells, they've shown we have increased fat cells inside the cells, increased fat accumulation. And oftentimes people like to say, well, that's because you're eating fat. I don't think it's because you're eating fat. Fat accumulation inside cells and tissues due to increased toxin. Now, yeah, you can consume toxic fats, but you can consume toxic things of any source. So increased toxins, reactive oxygen species, free radicals, and these molecules, these toxic molecules have to be stored somewhere. So frequently what the body does, it'll create a fat cell and store it there, or push it into interstitial space. You get lots of swelling and edema. And so these toxic substances have to be pushed aside so that the body can at least carry out its normal biological functions. And so with type 2 diabetes, which is insulin resistance, the mechanism is at the level of the mitochondria. It's intracellular inflammation that it picks up. So you have an adverse effect on the insulin receptors, which don't receive insulin or recognize insulin, so they don't carry out the ability to remove glucose inside the cell. And of course, glucose metabolism within the cell is impaired for various reasons. So it's really an intracellular disease. It's a metabolic disease, and the insulin resistance is associated with cardiovascular disease because it has effects on endothelial cells, it has effects on smooth muscle cells, and of course, vascular tissue.
So you had mentioned during your presentation about people being focused on blood sugar levels, and that may not be the right thing to focus. Why is the thought out there that with regard to diabetes, that we should focus on reduction of sugar and more widely carbohydrates, and why is that prevalent in the medical industry itself? So if you can answer that.
Well, first and foremost, elevated blood sugars are a problem. Elevated blood sugars, like hemoglobin A1C, represents glycosylated red blood cells, and the amount of blood sugar, glucose in the cells can affect the immune system, can affect, it can damage vessels. So elevated blood sugar in of itself can be a problem. The reason I say don't just focus on the blood sugar itself is because there are many other aspects to that problem. So the point I like to focus on is, okay, why is the blood sugar elevated? Yes, an elevated blood sugar is a problem. I had a patient admitted with diabetic ketoacidosis. He had, an acute inflammatory reaction to the pancreas. And yeah, we gave him lots of insulin to get the blood sugar, get the acid out. We have to do these things. So these things are a problem. Yes, if someone's blood sugar is 500, we're going to bring it down. So that's not the point. The point is, you don't just say, oh, blood sugar high, get the blood sugar down, we're done. No, if someone's on a diabetic medication or requiring a diabetic medication, whether it's insulin or metformin or whatever, to keep the blood sugar down, then I say, well, the problem hasn't been addressed. So then you have to say, okay, what's the underlying metabolic factors that are contributing to that blood sugar having to be up? You have to medicate something. In other words, I use blood pressure in analogy. Somebody with a normal blood pressure on an antihypertensive medication has high blood pressure. Somebody with a normal blood sugar on a blood sugar lowering medication has high blood sugar. And so just because the number is low doesn't mean the underlying pathophysiological process is corrected.
So that actually brings me to my next question, which is regarding the keto diet and diets like that are so wildly popular, and people love to go into ketosis and get their blood sugar down to, I guess, effectively zero. Why does this remain popular? And with regard to what you were just saying about undermining the disease in the first place, or bringing about the insulin resistance in the first place, how does that all play a role, and why do people still believe in this?
It's very interesting. And on my channel, oftentimes, in fact, I was reading a comment this morning, and someone commented on a case where I showed the patient's kidney function, heart function get better. And they said, oh, that's amazing. I achieved the same thing doing exactly the opposite. I went on a carnivore diet, and my heart disease, diabetes went away, et cetera, et cetera. So we hear that. Our next study is going to look at the defined plant-based diet against the Mediterranean diet, and then after that, at some point, we're going to have to compare it to the carnivore diet, certainly in the acute patients. One thing I can say is the following. Individuals are getting improvement because they're removing toxic chemicals from the diet. Animal proteins are not the only poisonous foods that we consume. In fact, there are lots of processed vegan foods and chemicalized foods, preserved foods, et cetera. And one can make a strong argument that the increased preservatives in our food are the biggest problem. So if you say, okay, you're on the Atkins diet or whatever, and maybe you're consuming some dead animal flesh, but basically you're getting healthy greens and other things, and you're not eating candy bars or vegan, whatever, this, that, and the other that are, laden with, 55 preservatives or whatever the case is, then you can make the argument that you're going to get some benefit from that. And so people can get benefit from removing toxic substances from the body. Now, so then which is better, a natural plant-based diet, or like we call ours, the fine plant-based diet, or a so-called healthy carnivore diet? And we're going to look at that certainly in the acutely ill patient. So the question I tend to ask, which I don't know the answer to, what if you take that patient I gave you an example of today that got better in 5-7 days on a smoothie feast? Could I put on just steak and potatoes because you've gotten better in 7 days in the same condition? I don't think so. I don't know if anyone's done that. So oftentimes I know people, so you have to think of the context of these things are discussed. The nice thing about comparative studies head to head, you put both, interventions in in the same context, and you follow it over time. And so that's what we're gonna have to do. I'm gonna have to, check my ethics committee board, but we'll have to bring some decompensated heart failure patients, put them on a keto diet, a carnivore diet, that's shorter breath, and put some on our defined plant-based diet, and let's follow them over time and then see how they do. And then I'll be able to I'll have an answer for you.
I would love to see that documentary. So,
Yeah.
and for people who do go on the keto diet for the long term, given that it's believed that they are actually increasing their insulin resistance after they've been on this diet for a while, can that be undone, or is there permanent damage?
It's a great question. A lot of it depends. Reversibility is one of those things that's variable, and it depends on the extent of it. I saw a talk a few weeks ago. I'm gonna bring the physician on who gave a nice presentation in terms of like someone with type 1 diabetes potentially being able to reverse it. And we've had people who were labeled type 1 who reversed it, but I always attribute that to the fact that they were misdiagnosed. But theoretically, if it depends on if the tissue source, whether it's the pancreas in the case of diabetes, or the heart and the brain, are those cells suppressed? Or are they irreversibly damaged or killed? So if the cells are killed and irreversibly damaged, scarred over, then there's not much chance of reversal. If the cells are severely depressed or suppressed, then that insulting process, if it's removed, can allow recovery. So, and it's hard to measure that, in our usual, clinical setting.
Thank you. So, what advice do you have for cardiologists and other healthcare professionals who are interested in incorporating nutritional counseling into their practice?
I think first and foremost, we have to have a change in mindset. And what I mean by that is that we have to step back and look at the body as a whole. So my training in medical school, and we learn about the whole body, and then you go to, you do your 4 years of medical school. Then I trained in internal medicine, where we, looked at adult, chronic illnesses as a whole. So we look at the cardiovascular, the endocrine, et cetera, et cetera. And then I went and specialized. So internal medicine is a specialty of itself, and then I subspecialized in cardiology, and then focused on the cardiovascular system. Then I subspecialized in cardiac electrophysiology, where I just think of the electrical abnormalities in the heart. And our medical training or medical indoctrination, if you will, puts us compartmentalize our thinking. To where someone says, "Oh, atrial fibrillations, arrhythmia in the atrium," but atrial fibrillation is a systemic disorder. And so, what I would like to share with my colleagues is to step back and think of the body as a whole, readjust our thought processes in terms of how we deal with heart disease or disease in general, cardiovascular disease in particular. And if somebody who's presenting to you with, coronary disease, who've had a heart attack, step back and say, "Okay, well, why did they have a heart attack?" And they may have other types of diseases that may be a trigger to that acute event. And so we need to think of our patients as a whole, think of them as a biological system in total, and treat that biological system as a whole. And so if you start that mental construct, then nutrition becomes a logical first step or I should say optimal nutrition becomes a logical first step toward helping the patient get better.
Thank you. So, can you elaborate on the differences between LDL and HDL cholesterol and the optimal levels patients should aim for according to your research and experience in your practice?
LDL cholesterol is the one that we think is more the atherogenic component. It's prevalent in the large VLDL molecules, but the atherogenic molecules like ApoB. So it's the cholesterol that's associated with plaque development. And also the small LDL particles are also atherogenic. HDL removes LDL from the bloodstream, so it's thought to be the police. Again, ideal levels of LDL, you certainly want your LDL cholesterol. I tell my patients, with heart disease, if it's less than 100, it's good. Again, back to my earlier statements, that in of itself is not the end all be all, it's how you get there. So, if their lifestyle is optimal and they're doing everything great, the LDL cholesterol is 110, 109, I'm not going to make a fuss of it. I'm certainly not going to put them on a statin. Sometimes we use supplements, sometimes we optimize their diet. But LDL cholesterol, the data is shown in people with heart disease, you want to get that lower. Somewhere in the neighborhood, less than 100 is ideal. Some people showing even 70. Again, it may be beneficial for heart disease, but getting LDL cholesterol, unnaturally getting it there, may not be the best way to do it. Naturally getting it there is going to be good because that means the body's in homeostasis to where you don't need that much LDL cholesterol. So then the LDL cholesterol is going to naturally be low. HDL cholesterol, we used to think, high HDL cholesterol is good. They've made medication to increase HDL cholesterol. These drugs have become more problematic. There's not been a lot of data showing benefits of HDL cholesterol. In fact, we see someone get on a healthy diet. When the LDL cholesterol come down, the HDL cholesterol will come down also. I like to think of the HDL cholesterol as police. How many police do you need? I don't know. Depends on how dangerous the neighborhood is. If you have a neighborhood watch system, you have good school systems, and the kids are raised right, the jobs there, and there's no, crime, etc. You don't need any police, or maybe one or two, if traffic stops or whatever. But if there's a lot of crime, a lot of craziness going on in the community, then you need a lot of police. So the amount of HDL will depend on, in my opinion, what's needed. And oftentimes people have high HDL levels because they have lots of atherogenic molecules around that needs to be removed.
So, what are the biggest challenges you face in convincing the medical community about the efficacy of dietary interventions for chronic disease?
Well, I mean, it's just upfront the importance of it. Now, I have individuals who I admit to the hospital and they have like acute coronary events, and we'll put them on a nutrition plan, et cetera. And again, I hear, my colleagues, one, there's no level of intellectual curiosity about it. They joke about it. So I think it's just they're just not aware of it. I mean, it's you know, uh, how do I teach a cockroach to ballet dance? I'm not sure. I mean, it's just,
Okay. I love your no, I didn't mean to interrupt you. I love your analogies.
incapacity, of the brain. So it's hard.
Okay, so what is your stance on the use of supplements in conjunction with a plant-based diet? Are there supplements? Obviously, B12 is a popular one that I think basically all the doctors I've encountered say you should be on. Are there other things that everyone should be on? Are there things that are hyped up with regard to supplements that maybe people should avoid?
Yeah, there's a great question about supplements, and supplements is one of those things that we need to, give a lot of thought to. Our approach is simply this: we try to measure uh, um, levels of micronutrients. There's a special blood test that looks at intracellular micronutrients. We send it off frequently, use that. And we try to use that as a guide. And I mean, there's no one test that's perfect in my opinion because the biological system is just so complex. But we try to use blood tests as a guide to say, okay, where are the key deficiencies? And then we will target supplement in those areas. In addition to that, we'll then have them consume foods, plant foods that are rich in those micronutrients that they have a deficiency in. So we'll use targeted micronutrients. Also, we'll have food sources, so we'll skew the diet. We also recommend people consume algae. I mentioned the ether algae, sea moss, grasses. These things are high in minerals and proteins and micronutrients, and so they will help supply the body with lots of micronutrients, because there are many micronutrients we don't measure routinely or can't measure. And so you want to supply the body with superfoods that have a large amount of these minerals and micronutrients. Supplements you have to be careful with. One, how do you procure your supplements? We say, oh, take a B12. Well, I mean, patients may go and get a B12 over the counter. I don't just say take it. If they need a B12, we have a B12 that we get from a source that's specially formulated, it's tested, et cetera. And so we supply them with the micronutrients that we think that they need. And so, this is, I think, very important, largely because supplements can have an adverse effect also. I mean, nothing's a free meal ticket. And supplements, by definition, are not natural. So yes, we do supplement on a regular basis. We try to do it in a targeted fashion. But as an adjunct, or should say the main treatment, we try to help our patients find natural nutritional sources for these micronutrients as well.
Okay, so about 14 minutes left. I'm going to throw it out to the audience for a couple of questions. So David R., please state where you're from and ask your question.
Hi, I'm from Massachusetts. Good morning, doctor.
Good morning.
I would like to follow up on the discussion about the cholesterol level and statin. I'm on a plant-based diet for about 10 years, living quite a healthy lifestyle. I have no heart symptom, but because of high calcium score, I did coronary CT angiogram analyzed by Clearly AI, and they found that I have about 40% blockage in one of my arteries. I did advanced lipid panel, and they found that my total cholesterol is 135, LDL 73, but they found very high LDL particle level of 1400. And I have also low inflammation. The CRP was 0.5. If you would have such a patient with such a detail, would you recommend him to take statin or red yeast rice to lower the LDLP? And how often would you recommend to do again the coronary CT angiogram as a follow-up? Thank you.
It's a great question. So you mentioned being on a plant-based diet for 10 years. My approach to this, so let's say a patient walked in exactly with the scenario you presented. First and foremost, I look at the diet. Plant-based diet doesn't tell me anything. So I say, okay, exactly what you're eating over the 10-year period of time, because that can make a huge difference. And so a large percentage of the time, we can make some changes in that nutritional regimen. So I had a patient come in, similar situation. He was on a plant-based diet, low fat, et cetera, et cetera, et cetera. He was cooking just about everything, microwaving most of it. He had poor dentition because he had to microwave it. He was having angina, very bad, poorly calcified valve. He's a very severe case of coronary disease, very difficult to treat. But we started him off with a smoothie feast because he had poor dentition. I would put him on raw, but he couldn't chew the solid raw, so put him on smoothie feast, ECB therapy, and his angina went away. Reduction requirement of nitroglycerin went down significantly. He improved significantly. So by significantly changing the diet, and that's why we call it a defined plant-based diet. And when we published it initially, we attached that phraseology to our food classification system. So first, I'll start with being more precise with how the nutritional regimen is applied. Mentioning calcified coronary arteries, that's what chelation comes. You're not going to stent the 40% lesion. So in the allopathic world, you're going to wait till it becomes 70%, then you'll stent or bypass it. But we may treat that individual with an aggressive raw detox diet. We may use Plaquex infusion and chelation infusion in combination. Plaque X can help reduce lipids, cholesterol levels as well. Chelation will help open those arteries up and improve coronary flow. And then over time, we'll follow those lipid particles. And typically what we see is those lipid particles improve with things like time-restricted eating, a precise plant-based diet, intermittent raw detoxes mixed with some cooked, etc. But when you cook your food, we have to, cook it in a precise way. Obviously, like on fry it, but you also, we don't recommend microwaving. And so we try to be very precise in terms of how the food's procured and how the food's prepared. And I learned even yesterday with Dr. Ryan, man, we promote organic. He's saying, well, yeah, a lot of organic greens don't have as much nitric oxide. So we have to rethink that whole process. So, probably have to go and start measuring the nitrites in the foods that we order for our patient.
All right. Next question is going out to Cheryl L. Please state where you're from and ask your question.
Yeah, hi, Doc. I'm from Maryland.
Good morning.
It's kind of a good morning. It's kind of a multifaceted along the same line of diet, but in the plant-based community in general, there seem to be differing opinions about some of the basic ingredients like SOS, and oil, no oil, olive oil, no olive oil, salt, no salt, etc. And so that's part of the question. I'm wondering, have you seen clinically that any one of those particular elements is more important for the control of blood pressure specifically? And also, like, for instance, I know I dropped my blood pressure significantly when I took oil out. I stopped using it at all and cooking, etc. And of course, some sneaks in here and there with different things you may eat, but for the most part. And so that's one of the questions. But that to me relates to the overall theme that I think is that all disease is related to inflammation. And so if that's true, and specifically also with regard to blood pressure, do you see, just if somebody is plant-based diet for the most part, and no, I don't mean processed plant-based diet, I mean following a healthy lifestyle, is there an element that you see within the food kingdom there that's more contributory to high blood pressure? Thank you.
Great question. And I understand the nature, the complexity of it, because it does get complex. In the plant-based kingdom, we all agree on plants. We have to find something to argue about, salt, no salt. But to address the first component of the question, the oil and salt and the like, we don't propose oil. Now, when you think about, know this, know that, sometimes you have to step back and say, okay, what's the context of it? So for instance, we like cold pressed juices and smoothies, and you hear Dr. Esselstyn, you don't like smoothies and cold pressed juices. And it's not like, okay, well, one's right, one's wrong. You have to think about the context of it. When we look at cold pressed juices, we're looking at cold pressed juices. It's raw, extracted, etc. You're getting the best produce, etc. When people think about juices, oftentimes it's pasteurized off the store, and that's a problem. Also, we're looking at it in the context of someone who's very sick, who can't chew, or whatever the case is. So oftentimes you have to look at these things in context. So back to your question, oil. We tend to say stay away from oil. Seed oils are the worst because they're, chemicalized, extracted, heated, et cetera. Oil from a pulp, avocado is supposed to be, more tolerant of heat. But the problem is that when you're getting these things off the shelf, they're highly commercialized foods. I was looking at a document just last night, in fact, talking about olive oil. It's all in a cold pressed olive oil. Most of the cold pressed olive oil is not cold pressed, and it's some of it's some olives, some of it's some other stuff. And so you don't know what you're getting with the oils, and these foods can be rancid. And they can be very problematic. You can make a similar argument for wheat, because the wheat's a very commercialized substance. A lot of wheat has, abnormal gluten molecule. It's not the original wheat people ate thousands of years ago, et cetera. So you have to look at the context in which these things are. So oil, I think it's safe to remove from the diet. Salt, by and large, yes, you want to remove it, because most forms of salt comes in the form of preservatives, it's in the form of a overly processed salt. So that's going to be bad for you. However, we have patients that we see who have probably due to poor adrenal gland function, a lot of heart failure patients, low sodium, they have low blood pressure. We have to, add salt to their diet. Now, we don't add regular table salt. We'll add like a Himalayan sea salt or a Celtic salt that's like the whole mineral and not an extraction of the mineral. So in some contexts, we have to add salt to the diet, certain people, certain, illness in certain situations. And in my practice, we see a significant number of these people. It's not like every other patient, but a significant number of patients. And so you have to look at the context of this, situation. How food's prepared is important in terms of the nutritional regimen. And is there another part of that question I'm leaving out? I don't want to, there was a great question that I don't want to leave it out. If you want to come back on and just
Yeah, sure. Cheryl, go ahead. Was there anything else?
Well, it really relates to the overall theme of inflammation, and inflammation being at the root cause of disease.
Yes, good question. So inflammation, I think I think it has it's a counterpart to oxidative stress and abnormal microbiome. So yes, inflammation is one of those root pillars. And inflammation is brought on by lots of different things. Exercise can cause inflammation. Exercise is a good thing. And the other point I wanted to make along the lines of inflammation and along the lines of diet is also we need to be mindful of micronutrients. And in our last conference, a colleague of mine who is an expert in micronutrient analyses, you want to test for these micronutrients because, again, our food sources have been compromised and the minerals and things that we get are not quite adequate. And it's hard to really know. I mean, for instance, if your blood pressure is very high, what if you have a zinc deficiency or intracellular magnesium deficiency? And you're not getting the blood test may show the magnesium to be normal, but the blood pressure will be high because these micronutrient tests are abnormal. Or there may be some antioxidants that are more protective for your system than others. So we start to look at these things in addition to that. So inflammation is key. Getting that down is important, but also get some understanding of the micronutrient balance. If there are micronutrient imbalances, you may need a probiotic to help with absorption. You may need targeted micronutrient or mineral supplementation to target those minerals to improve things. And we've had patients who are on plant-based diet, they're doing well, blood pressure very high, and we see the magnesium low. We supplement magnesium, blood pressure comes down, the sleep improves. So micronutrients is another component. So our system of food has gotten to be so complex. Our approach needs to be more precise and more detailed. It's not enough to say whole foods, plant-based, SOS. Yes, that's a reasonable start, but you have to pierce into things. You may have to add more raw, more time-restricted eating, more micronutrient analyses and targeting, and some of these adjunctive therapies to help reverse some things that have been accelerate reverse of some of these things like mitochondrial function, endothelial, nitric oxide production may be severely impaired. And it may not be enough to be on an SOS diet to enhance that. You might need to supplement nitric oxide to a certain extent while you're eating your leafy greens. And of course, you need to make sure leafy greens have adequate nitrates in them. And so there are a lot of different things that we have to look at from a biochemical standpoint as we try to nourish the body.
So we just have about 30 seconds. So I'm going to ask you a question. You may not know about the subject. You may, because it was the first time I had actually heard about it. We had a PhD by the name of Dr. Michael Nels on as a presenter, and he brought up lithium as something that he recommended people taking, that it was originally in the environment. It is no longer in our, found in the environment, kind of like B12. Just within like 30 seconds, if you can, what are your thoughts on lithium supplementation, and are you aware of it?
I don't have personal knowledge, but he may be right. I mean, I'm learning things every day, so I'd like for you to send me a link to that talk. Or maybe send me a link to that, maybe one of his papers. I would love.
He has actually quite an extensive paper on Substack. If you look up Dr. Michael Nehls, Nehls, and we can have John send you the link. I actually have the link if you'd like.
Yeah, email me the link, please.
We will absolutely do that.
So I learned something. That's good.
All right, perfect. Maybe next time you speak, you'll be doing a whole presentation on the power of lithium.
I'll be talking about all the lithium measurements we made and all the changes.
That's great. So with that concludes our time. So thank you so much for that extremely informative presentation. Yeah, I really enjoy the information that you share. If we can unmute the audience, please.
Thanks, Doctor. Appreciate it.
Thank you. Appreciate it. Amazing.
Oh, that's so much. I thought it was